Hi everyone, Dr. Windsor here. Welcome to our first pharmacology lecture. This lecture will focus on chapter 1 and cover the basics of pharmacology. So after completing this lecture, you should have a better understanding of some of the basic terms and abbreviations associated with pharmacology. Also, you should be able to state sources of drugs and provide examples from each of those sources. In addition, you'll have the ability to list and describe several classes of drugs that are utilized in surgery. During this lecture, we're also going to take a closer look at medication orders, drug distribution systems, drug forms, and routes of drug administration. And if that wasn't enough, I will explain the process of pharmacokinetics as well as discuss the various aspects of pharmacodynamics. So it sounds like we have a lot to learn in this first chapter, so let's go ahead and get started. Before we dive into the content of chapter 1, I want to ask you a question. Why is learning about pharmacology so important in the role of the surgical technologist? Go ahead and pause this lecture and take a minute and jot down anything that comes to mind. Okay, so hopefully you paused, you took some time to do some brainstorming. Were you able to come up with any reasons? I prepared a list But before I tell you what's on my list, I want to provide you with a couple of statistics. Did you know that more than 7,000 deaths each year are attributed to medication errors? This accounts for approximately 10% of all deaths associated with medical errors. I don't know about you guys, but I was shocked and horrified to discover that a study conducted at Massachusetts General Hospital and published in October of 2015 discovered that medication errors occurred in over half of the surgical procedures that were performed there. And one last tidbit of information before we get to my list, and I think you know where I'm going with this. Research indicates that there have been documented instances of surgical patients dying as the result of receiving an incorrect drug due to the drug-containing basins and medication cups not being labeled. So as the surgical tech, we are instrumental, absolutely instrumental in reducing medication errors that can occur in the surgical setting. And most importantly, death due to those errors. We are the extra eyes and ears, right? So how do we do this? Well, according to the Association of Surgical Technology, we should follow 6 general guidelines, which include following the 6 rights of medication, including handling and dispensing, following sterile technique when medications are dispensed onto the sterile field, handling medications in the operating room under the direct supervision and orders of the surgeon, assisting with the development of, knowing, and adhering to the surgery department's policies and procedures that mandate who should be involved in administering and dispensing medications in the perioperative setting. A couple more here. Participating in the review of those policies and procedures. And lastly, completing continuing education so that we can remain current in our knowledge of safe medication practices. So we will dig deeper into each of these as we progress through the contents of this course, but for now, I just want you to understand the importance of your role in safe medication practices in the operating room. You are an essential component in ensuring that your patient gets the right drug at the right time. So now that we have a better understanding of why pharmacology is essential in the role of the surg tech, let's begin by reviewing some terms related to pharmacology. So pharmacology is defined as the study of how chemicals and biological systems interact. Heparin chemical, for example, is a drug, right? It's a chemical that binds to something called antithrombin in the blood, right? In the cardiovascular system. And what it does is it inactivates the clotting process, and that thins or anticoagulates the blood. So in the broadest sense, the science of pharmacology includes toxicology, which is a branch of science concerned with the nature, effects, and detection of poisons. It also includes food science, agriculture, and lastly, medicine. So in the areas of medicine, new drugs are being developed almost every day, and it's not a new concept that change is a constant in medication, and the branch of pharmacology is no exception. So as surgical technologists, we need to understand current medications and trends, but also develop the ability to incorporate new medications in our surgical practice as they come available. So as I was putting this together, I started thinking back to a time when I first started working in the operating room. And not too long after that, Dermabond, which is a type of surgical skin glue, it did not exist. And surprisingly, surgeons look to us, the surg tech, on guidance regarding how to use it. So we have this new fandangled thing called skin glue, and the surgeons are just befuddled by it, right? So while the surgeons did receive training on the use of Dermabond, it was not consistent with their existing knowledge. The use of something like skin glue was very foreign to surgeons. I observed two major hurdles in surgeons using this new medication. First was that they needed to apply Dermabond in 3 light coats, allowing for some time to dry between each coat. Surgeons don't think that they have time for this, so they just want to slop it on and then it doesn't dry and it gets smeared everywhere. The second thing was that they were adamant about applying the Dermabond and covering it with a dressing. They had always covered the wound with a dressing. This was really foreign to them, that putting on the Dermabond meant that they didn't have to cover the wound with a dressing anymore. And so as the ST, it was my responsibility to clearly understand how Dermabond was used and to guide my surgeons accordingly to, ensure that the patient would have the best outcome possible. So to summarize, an understanding of pharmacology basics, like the terms and abbreviations, can help with comprehension of current science and integration of new information. So let's review a couple of terms now. The first is adverse effect. An adverse effect is an undesired or potentially harmful side effect of a medication. For an example, an adverse side effect of heparin is heavy bleeding or oozing from cuts or wounds. Remember, heparin is an anticoagulant. It thins the blood. The second term I want to go over is bolus. A bolus is defined as a dose of medication that is given rapidly, typically through an IV. So, for example, a person with diabetes, a bolus would be a dose of insulin that would be given to handle the rise in the patient's blood glucose level, right, which is their blood sugar. Okay, so 2 additional terms that we should know are contraindication and absorption. So deeper into the lesson, it will become clear how these terms apply, but for now, Understand that a contraindication is a reason against giving someone a medication. Some of the most common reasons for not giving someone a medication, in other words, giving the medication would be contraindicated, are things like sensitivity or allergy to the medication, pregnancy, lactation, renal disease, and hepatic disease. Now, absorption is the process by which medications are taken into the body. Absorption is how the drug gets into the bloodstream, and there are several methods of absorption, which we're going to talk about in greater detail later on. So next, we're going to take some time to discuss the various drug sources. Now, a drug source is where the drug originates, and there are three major drug sources that we're going to cover in this lecture, and they include natural, chemical, and biotechnology. So, as mentioned previously, drugs today come from three main sources: natural, chemical, and biotechnology. So we're going to talk about each of these in a bit more detail. So take a look at this amazing chart that I made you to show you the three main natural sources. So that would be plants, minerals, and animals. And we're going to talk about each of those. Now, plants are one of the natural drug sources, and at one time they were probably one of the only types of natural drug sources, but they've become less and less common in the surgical arena. However, when we look at alternative medicine, we will find it has a lot to do with the use of plants, okay? So some examples of medications that come from plants: atropine, morphine, and digitalis. Now, morphine is a narcotic, and it comes from the seeds of the opium poppy, all right? Whereas atropine, that's a drug that reduces secretions and causes smooth muscle relaxation. It comes from the roots of a plant called the belladonna plant. And then lastly, digitalis is from the leaves of a purple foxglove, and it is used to treat problems such as arrhythmias and congestive heart failure. So those are just three examples. There's more, of course. Let's talk a little bit about minerals. Minerals is another natural drug source often used in pharmacological agents, and two examples are sylvadene cream and antacids. Probably most of us have taken Tums or Rolaids or Mylanta or something of that sort. So antacids such as let me back up. Sylvadene cream, let me talk about that first, contains silver salts. And when we have patients that have burns, this sylvadene cream is what we typically put on those burns. And then antacids such as Tums and Mylanta, they contain calcium and magnesium respectively. So now a little bit about animals, our third and last natural source of drugs, and particularly hormones. And some common sources include pigs, which you will hear referred to as porcine, cows, which we refer to as bovine, and horses, we refer to that as equine. So some common example hormones derived from pigs include insulin, which is used to control blood glucose levels. It has also been derived from cows as well. Another example of a hormone that's derived from pigs is thrioglobulin, which is a thyroid hormone. Also, thrombogen, which is a topical hemostatic. It helps to stop bleeding. that is derived from cows. So we refer to that as a bovine derivative. And then primarin. Primarin is the hormone estrogen, and that is derived from the horse. So we refer to that as equine. Now, if you take a look at table 1.1 in your textbook, there are some other examples of plant-derived drugs that are relevant to the surgical practice, so be sure to take a peek at that. Now that we have a better understanding of natural drug sources, let's take a closer look at chemical sources. So if natural sources are the first sources of drugs, then chemical synthesis is definitely the second. Now, chemical drugs fall into two categories, and you can see them in green on the slide in front of you, and they are synthetic and semi-synthetic. Now, synthetic drugs such as the pain-relieving drug Demerol are created or synthesized in the lab, and they do that by only using laboratory chemicals. Aspirin is a good example of a semi-synthetic drug. It is derived from a natural substance called salicylic acid. Now, to synthesize semi-synthetic drugs such as various antibiotics, amoxicillin is a good example. Scientists will first extract the active substance from penicillin mold, and then they'll purify it and alter it using chemical processes. A similar process is used to synthesize antibiotics that belong to the aminoglycoside group. However, the active substance found in the bacterial species Streptomyces is extracted to create antibiotics such as gentamicin and streptomycin, as well as a variety of other ones. So next we're going to talk about biotechnology. So as I mentioned, biotechnology, it's the third and last drug source. Biotechnology refers to the concepts of genetic engineering and something called recombinant DNA. Remember, DNA is deoxyribonucleic acid. It is the genetic material that is contained within cells. And so thanks to biotechnology, we've been able to significantly improve treatment for a variety of conditions. Now, biotechnology is used to produce proteins from bacteria, and previously these proteins were only available from animals. Using biotechnology, here's what they do. Scientists will alter the DNA of a bacteria to produce the proteins that they need to make drugs. So scientists have used cells such as E. coli. Remember, E. coli lives in our digestive tract, and what they do is they take a very, very small microscopic piece of genetic code that tells the cell to make a certain protein. So that is going to be inserted into the E. coli bacteria, and that little piece of genetic code is going to get incorporated into the bacteria's DNA, and then it is going to use that code to produce the proteins that we want it to produce, and it can do it really quickly, which is awesome. So it starts producing the protein, and that specific protein is then extracted, and it goes through a purification process in the lab. More recently, though, scientists have been using mammalian cells of mammals, such as those of the Chinese hamster ovary. They shorten that to CHO. So those are becoming the primary cell of choice because they have a more stable gene expression. Bacteria have a tendency to replicate themselves so fast that sometimes they make mistakes. So less mistakes and higher volumes of the desired proteins. So using biotechnology is really great because it can create proteins without animals, and it can avoid the adverse side effects of animal-derived drugs. So some of the drugs shown here, like humulin, alteplase, growth hormone, and hepatitis B vaccine, are some of the drugs produced using biotechnology. Humulin is human insulin, and activase, also called alteplase, is a thrombolytic. So it is used to break up blood clots. Neutropin is a human growth hormone. And then another example is thyrogen. Thyrogen is a thyroid stimulating hormone. And then lastly, we have our hepatitis B vaccine, which is of particular interest to us, right? Because we are required to get the Hep B series as healthcare workers. All right, so a little side note here. These drugs can only be administered via injection, and this is because they are proteins. And if we were to take them in a pill form or something that we had to swallow, the proteins are going to be broken down and consumed in our stomach. So before we finish up our discussion about biotechnology, let's take a little look at figure 1.3, which illustrates how biotechnology works using E. coli. So in essence, the E. coli bacteria act as these little bitty protein producing factories. So part A shows the DNA of the E. coli. And then scientists insert into the E. coli's DNA a gene that's going to code for a certain desired protein. That's the part B. And then in part C, we see that final step where E. coli incorporates the gene into its DNA, and then it's going to start replicating itself, all the while producing those proteins. All right, so now we have a better understanding of the three types of major drug sources. Let's move on to talk about drug classifications. So as surgical technologists, we need to be able to classify or group similar drugs. Why do you think this is? Well, the truth is, when we understand how drugs are classified, we can group and understand new drugs more easily. And as I mentioned, new drugs are coming out all the time. So let's revisit the aminoglycoside group of antibiotics, and you will find this true with other groups of medications as well. So it's a little trick that I learned, and I want to pass it on to you. Remember, I said that the aminoglycoside group of antibiotics are semi-synthetic drugs, and they're derived from the bacteria Streptomyces. They include drugs like gentamicin, tobramycin, amikacin, plazomicin, streptomycin, neomycin, and paramycin. So, do you notice anything about their names at all? Did you hear the sin at the end of each one? Let me read them again. Gentamicin, tobramycin, streptomycin, neomycin, right? So this is just one example of how we can group drugs together to remember and understand them more easily. If you can connect the fact that the majority of these aminoglycoside antibiotics end with the letters CIN, it's going to help you significantly, especially when it comes to taking a test or your certification exam. So on this slide, you're going to see the 4 common drug classification categories, and they are therapeutic action, physiological action, body system, and chemical type. And it's important to note that the drugs in each category, they have similar uses. So if you take a look at table 1.2, you'll see several categories of drugs listed under each classification type. For example, analgesic, do you see it there? It falls under the classification therapeutic action. An analgesic is used to relieve pain. That's its therapeutic action. Now, cholinergic drugs, on the other hand, they elicit a physiological action. So what do? They activate the parasympathetic nervous system. Let's move on to cardiovascular agents, right? They focus on a specific body system, right? And then lastly, let's look at barbiturate. Find it there in the chart, right, under chemical type. It's classified by its chemical type because it's derived from a chemical called barbituric acid. All right, next we're going to dive a bit deeper into each of these drug classifications. So a couple important side notes about drug subcategories. When we classify drugs, there are some important things to remember. Interestingly, subcategories are more useful than the broad categories. Well, why do you think this is? Well, the reason is because subcategories give more information or clues to the drug's use or purpose, like cardiovascular agents. That helps us out a lot, right? We're familiar with the cardiovascular system. So the use of medical terms as signposts when placing drugs in groups is really helpful. So let's use the term anesthetic as an example. The an in anesthetic means without, and aesthetic means pertaining to sensation. What about the term thrombolytic? Thrombo means clot, and lytic means pertaining. Remember, the IC means pertaining to the breakdown of something, right? So, but just a word of caution here, some drugs can belong in multiple categories. A good example of that is Zantac. Zantac is characterized as an antacid, a histamine receptor antagonist, and also a gastric agent. Similarly is our friend aspirin. Aspirin is classified as an analgesic because it relieves pain, but it's also classified as a fever reducer or antipyretic and anti-inflammatory because it reduces inflammation. So let's start by talking about therapeutic action drugs in more detail. Now, therapeutic action drugs, they do something for the patient. They do something for the patient. I already mentioned that analgesics relieve pain. So what do analgesics do for the patient? They relieve the patient's pain. What about an anti-inflammatory? What do they do for the patient? Right? They reduce the patient's inflammation. Similarly, thrombolytics break down clots, and antipyretics reduce fever. They're doing something for the patient. So take another look at table 1.2 and make sure you familiarize yourself with the other therapeutic action drugs listed there that I didn't mention. The second drug classification is physiologic action. Drugs in this category do something in the body. So ask yourself, what does a histamine blocker do in the body? For example, histamine blockers block histamine production. What about a vasoconstrictor? What do they do in the body? If we think about what we know regarding our use of medical technology, vaso means blood vessel, and constrictor refers to a muscle that contracts. or it could be referring to a snake. Anyway, so a vasoconstrictor causes the smooth muscles in the wall of the blood vessels to constrict. That's what it does in the body. All right. Similarly, H2 receptor antagonist. Remember, an antagonist opposes something. And so an H2 receptor antagonist prevents or opposes the production of gastric acid. So these are just a couple examples. Again, be sure that you familiarize yourself with the rest of them in table 1.2. So we're going to move on to the third drug classification, which is affected body systems. As its name suggests, drugs in this category are going to affect a targeted organ or organs of a body system. So ask yourself, what organ or body system does the drug affect? I already mentioned that cardiovascular agents affect the heart and circulatory system. So what about dermatologic agents? Remember, dermato means skin, and logy means the science or study of, and ic means pertaining to. So dermatologic means pertaining to the science or the study of the skin. Now, cortisone cream is an example of a dermatologic agent. What about a gastric agent? What organ or body system does the drug affect? If you thought stomach, you are correct. So great job there. Again, these are just a few examples, so make sure you check out the others that are listed in table 1.2. So here we are at the fourth and final drug classification, which is chemical type. Drugs in this category are grouped because of what they are, right? What chemical compound is the drug derived from? Barbiturates, as previously mentioned, are chemical compounds derived from barbituric acid. Benzodiazepines are also sometimes referred to as benzos, and they are a class of depressant drugs whose core chemical structure is the fusion of benzene and diazepine. Benzodiazepine. It all makes sense now. Some examples of benzodiazepines are Valium, Versed, and Ativan, and a couple examples of barbiturates are pentothal and Brevitol. Again, take a peek at table 1.2. All right, we're motoring through here. We are on to talk a little bit more about just how we classify and subcategorize drugs. So remember, drugs can fall under more than one classification, and ranitidine or Zantac is a good example of that. So therapeutically, it's an antacid. Physiologically, it's an H2 blocker. Remember, that has to do with the production of gastric acid. It blocks that. And as a body system, it is a gastric agent. So drugs can fall under more than one classification. We also talked about aspirin and how aspirin has more than one classification. Okay, so to further complicate matters, there are more variations. Remember, let's review aspirin. Aspirin has more than one therapeutic action, right? So it has subcategories under one specific classification, right? Not one subcategory under three classifications like Zantac. So again, aspirin, its therapeutic effects are antipyretic, analgesic, and anti-inflammatory. Drugs can also be grouped by how we obtain them. So here we're talking about over-the-counter and prescription drugs. And these two categories are considered legal classifications. Now, over-the-counter drugs, they don't require us to have a doctor's prescription, and we can just go into the store and find it on the shelf and take it, to the checkout counter and, leave with our aspirin or our ibuprofen or our Flonase or whatever the case may be. However, prescription drugs are prescribed by a doctor or licensed medical professional, and they have to be purchased at the pharmacy. In addition, prescription drugs can only be used legally by the person that the drug was prescribed to. Legally, right? If we buy something over the counter, we buy a box of Sudafed, and because I have the sniffles, and then a week later my mom has the sniffles, I can say, oh hey, I have some Sudafed, here, I'll give it to you. Not supposed to do that with prescriptions. Doesn't mean that we don't do it, but legally we're not supposed to. It's good to remember that both are regulated by the Federal Drug Administration, the FDA. So we'll dive deeper into the details involving over-the-counter and prescription drug legalities in Chapter 2. So stay tuned for that in a future lecture. Surgical techs need to know all about drug classifications and subcategories. And this information is critical in helping us to understand how to handle and use a drug as well as how the drug works. So now we have a pretty good understanding of drug classifications and subcategories. I want to talk about medication orders. So surgical techs communicate about drugs through medication orders. Prescriptions are one type of medication order, but they don't cover the drugs in surgery that we use in surgery. A prescription is an order for a specific drug, like we talked about. Go ahead and take a look at figure 1.4 in your text, and you can see an example of a prescription. I put a couple examples up here on the upcoming slide as well. You'll be able to see a couple examples, but I'm sure all of us have received a prescription at one time or another. So notice that a prescription has several components, which include the date, the name of the patient, the name of the drug, the dosage, the route of administration, the frequency or time of administration, and the prescriber's signature. The government also dictates who can write prescriptions, and this is determined on a state level. So that means that this can vary from state to state. Other things that have to be on the prescription is the prescriber's name and address and telephone number, and something called their Drug Enforcement Administration number, or their DEA number. And while the prescription usually lists the drug's trade name, sometimes you might find the generic name listed there instead. It's also common for prescribers to use symbols and abbreviations, which are then interpreted by the pharmacist. So be sure to also familiarize yourself with the abbreviations noted in Table 1.3. So another thing is that many pharmacies now utilize computer database systems that provide printouts for patients regarding drug information, such as its side effects, precautions, normal usage, and storage. So most prescriptions are ordered electronically these days because there can be and have been a lot of difficulties when interpreting written orders. If you've ever seen a doctor's handwriting, you will know why I'm saying this. So, as previously mentioned, written prescriptions have little or no use in surgery. And in addition to that, all drugs used in surgery are going to be ordered by a physician. So you might be wondering, what do we do in surgery when we need to use medication? And that's what we're going to talk about next. So in surgery, medication orders are going to be one of several types, which could include standing orders, verbal orders, immediate or stat orders, and as needed or PRN orders. Now, a standing order or protocol, you might hear it called, is the first type of hospital medication order. And while hospitals at large may have standing orders that guide the use of prophylactic antibiotics prior to surgery, in the operating room, our standard orders come from the preference card. So stand by for an example of a preference card on the next slide. But a preference card contains standing orders for a particular medication that's going to be used in a particular surgical procedure by a particular surgeon. So the preference card is specific to surgeon and procedure. So for example, Dr. Vigil. Dr. Vigil is a peripheral vascular surgeon. His unique preference card for abdominal aortic aneurysm repair calls for 5,000 units of heparin, remember, which is an anticoagulant, in 1,000 mLs of sodium chloride solution, which is saline, and he wants this used for topical irrigation. As such, all medications are going to be listed on the preference card, and they should be ready on the back table as a standard part of the setup for that procedure. Now, verbal orders are also going to be common in surgery. And the surgeon might be doing a surgery and request a specific medication be administered from the sterile field. So the nurse is going to give it to us and we are going to prepare it, give it to the surgeon. The surgeon is going to administer it. Or the surgeon might want the anesthesia care provider to give some sort of specific medication. So let's say that Dr. Vigil might ask the anesthesia care provider to administer 5,000 units of heparin in the patient's IV. He might also ask for gel foam and thrombin, which is a topical hemostatic agent, to be delivered to the sterile field to help control excessive bleeding. And those medications that live on the preference card, those medications are standing orders. Every single case, we're going to have those, and we're going to have them ready in case there's, unless, let's say the patient has an allergy or the surgeon comes in and specifically says he wants to use something else, we're always going to have those ready. These verbal orders are typically a one-time single administration of the medication. So it's important to also note that all of the verbal orders for medications that are given during a surgery are going to be documented in the patient's chart. So let's talk about stat orders and PRN orders. Now, a stat order is a type of verbal order that indicates that the drug needs to be administered now, immediately. And commonly, stat orders are given during emergency situations such as cardiac arrest. Now, PRN stands for pro re nata, which is Latin for give as needed. So this PRN means the drug should be given as needed. For example, let's say that the patient is having a breast biopsy and the breast biopsy is being performed under local anesthesia and the surgeon suspects that the patient might need help with pain control post-operatively. He might order Demerol to be given PRN post-operatively to manage the patient's pain. So I hope that makes sense. So here is a look at the preference card and the medication orders for surgery that are stated on the preference card. They need to have at least 3 basic parts. So if you look at that area that I circled in yellow that says medication, that's the area that we're focusing right now. And again, there should be 3 basic pieces of information. We need to know the drug name, the strength of the drug, and the volume. How much are we going to have on our field? So if you look at this preference card, you will see that it does provide the name, strength, and volume of the drug. So it says the name is bupivacaine with epinephrine. The strength is 0.5% and the volume is 10 ml or milliliters. So you can see some abbreviations there. They use the W with the slash, they use the ml. Sometimes for gauge, they'll put a G instead of gauge. I just want to draw your attention to this because you're going to see many abbreviations that represent drug forms, and there's a table in your textbook. It's table 1.5 that gives some of those abbreviations, so take a peek at that. And that's going to wrap up our discussion about medication orders. So next we're going to talk about drug distribution systems. Suffice it to say, it's important to communicate about drugs properly, but it's also important to distribute those drugs properly, and different facilities have different ways of doing this. But this is the main tenet of drug distribution. And like I said, drug distribution systems vary, but in surgery, drugs are usually dispensed from one of 3 types of places, which can include the hospital pharmacy, some sort of OR satellite pharmacy, or a type of medicine cabinet or cart. Now, larger hospitals may have a satellite pharmacy within the surgical department, but smaller facilities may have a medication room or cabinet where they store frequently used medications. Other facilities may utilize mobile cart systems that are exchanged or need to be restocked at certain times of the day. Crash cart that's used during cardiac arrest is an example of this type of system. Lastly, facilities may choose to use something called computer automated dispensing systems. And these are a lot like vending machines, but sadly they don't have Doritos or Hershey's bars in them, but instead are filled with medications for distribution during surgery. Now, these systems have a variety of mechanisms that can help minimize medication administration errors, which is really awesome. It's important to also note that controlled substances like narcotics need to be stored in double locked locations. Typically, there's one person is designated to have the key or the code. 2 people count the drugs at the beginning of the shift and similarly at the end of the shift. I don't know if you guys have watched The Good Nurse, but if you haven't, maybe check out that movie. It's pretty interesting. It has to do with these drug dispensing systems. So from my personal experience, when I first started scrubbing, the facility where I was hired used a medication box system. So they were literally like these tackle boxes, these snack boxes, and they were stocked with commonly used meds, and they were exchanged on an as needed basis with the pharmacy, which means, somebody would have to go down to the pharmacy and take the box that was out of whatever and get a new one. But later on, the facility moved to the use of computer automated dispensing systems, and we had one in each operating room. It's called the Pyxis. And the machines were restocked at the end of the day, but the machines had like a little computer screen, and you had to have a code to get into it, which the nurses and the anesthesia care providers had. The surgical techs did not have access to that. But you put your code into the screen, and you pull up whatever drug you want and how many, and then a little drawer pops open with them in it, and you get them out and you shut the drawer. And so theoretically, at the end of the day, there should be that, inventory of the machine started out with this many vials of Demerol and 5 were used, and so this many should be left. And so it helps with tracking of the medication as well. Similarly, narcotics that were used from the drug dispensing system need to be wasted if the whole amount of the drug is not used. You can't just, throw it in the garbage can. It needs to be quote unquote wasted, which still should not be shot into the trash can. That's not a good practice. But narcotics need to be wasted with another person. Another experience I had was at a surgery center where I worked, and we basically had these they looked like rolling toolboxes. They were like red with the metal drawers that pulled open, and they were stocked with the surgical drugs. And anybody and everybody could have access to them that was in the hall. It had the lidocaine and, various things like that, but narcotics were not stocked in those carts. So some different examples, depending on the size of the facility, they may, have different distribution systems that they use. So after the second portion, so that was the first portion of the lecture. Phew. We got through that. So after the second portion, we will be able to list and describe types of drug forms, compare and contrast medication routes that we use in surgery, explain the processes of pharmacokinetics, and identify and discuss the various aspects of pharmacodynamics. It sounds so fun. Okay, first off, drug forms. So a drug form is the drug's appearance or how it is prepared. Now, drugs do come in many different forms and preparations, but can largely be grouped into 4 categories. And these categories are solids, semi-solids, liquids, and gases. So first we're going to talk about the solid form. And many drugs come prepared in this form. I'm sure we've all taken a pill before. That is a solid form of a drug, a pill, a capsule, a tablet, those kinds of things. These types of medications are not commonly used in the operating room. We may use some drugs that come as a powder or need to be reconstituted, such as dantrolene, but for the most part, our patients are out and we really don't want them to sit up and take a pill with a drink of water. We also think about, the immediacy of that we want the drug to act quickly, right? And taking a pill by the mouth doesn't do that either. So, like I said, powders or freeze-dried medications come in solid form, but then we usually add IV saline or something like that to them to reconstitute them back to their liquid form. Dantrolene is a good example of one. Remember, dantrolene is used to treat malignant hyperthermia. So moving on to semi-solids. Semi-solid drugs include creams, foams, gels, and also ointments. So creams consist of an active ingredient and they're water-based, but ointments have an active ingredient and then they are oil or petroleum based. And then gels are typically a little bit thicker than creams, but they're still going to be water-based. And there are a lot of semi-solids that we use in surgery. Some common ones include KY jelly, which is a water-based lubricant, lidocaine jelly, which is a water-based topical anesthetic, Sylvadene cream, which I mentioned before is that burn cream, estrogen cream, which is a hormone cream that sometimes the surgeon will use when packing the vagina, and Neosporin, which is an antibiotic ointment. Of course, this is not an exhaustive list, but some commonly used ones. So the third drug form is liquid, and there are 3 types, and those include solutions, suspensions, and emulsions. So solutions are mixtures of drug particles, and those drug particles that they're referred to as the solute, and then there is the liquid, which is the solvent. Now, solutions have the solute, and it's fully dissolved in the liquid. It completely mixes up. You can't distinguish the solute from the solvent. And an example of that would be saline or 0.9% sodium chloride. And the saline solution is sodium chloride, which is salt, that's the solute, and it is dissolved in water, which is the solvent. Now, suspensions are a little bit different. They have solid particles floating in a liquid, but the particles do not dissolve. They're undissolved. So the solid particles pretty much settle to the bottom of the liquid. So these medications are going to need to be shaken prior to administration so that those particles get evenly distributed throughout the liquid. And an example of this medication is one that we use in the ear. It's called corticosteroid otic, and this is used to treat infection of the ear and also to help reduce inflammation. So it's hydrocortisone and Neosporin together. Now, quick question here. How many of you have ever eaten mayonnaise? Mayonnaise is a common example of an emulsion. And emulsion is the third type of liquid that I want to talk about. Emulsions consist of not in the case of mayonnaise, but in the case of medicine, medication that is contained in a mixture of oil and water and held together with something called an emulsifier. And an emulsifier simply serves to bind those two substances together. Have you ever tried to mix oil and water? It doesn't work, right? So an emulsifier would be the thing that binds. In the case of mayonnaise, I think it's eggs. But the most common emulsion that we use in surgery is called propofol. And it is the image that you see in this picture. And I circled the proof on the label that this is in fact an emulsion. And propofol is, you might have heard it referred to as the Michael Jackson drug, but it is a sedative agent that's administered through the patient's IV by the anesthesia care provider in surgeries. Propofol is used for almost every single surgery that we do. before I move on, it's important to note that drugs in liquid form may be administered orally as something called elixirs or syrups. So probably most of us have had cough syrup at some time or another. Syrups are sweetened aqueous solutions, water solutions, and elixirs are sweetened solutions of alcohol. So elixirs and syrups. But again, due to the surgical patient's inability to receive medications through the mouth, elixirs and syrups are not typically used in surgery. Okay, our last form, our drug form, is gases. They're the fourth and final drug form, and really, nitrous oxide is the only common medication that is available in gas form. However, we do use some inhalation anesthetic agents in surgery. However, and some are depicted in this picture that you see here on the slide, but they don't start out as gases. They are actually considered volatile liquids. And what we do is we put these liquids into the anesthesia machine, and it has a vaporizer. And so the anesthesia machine is going to vaporize these volatile liquids into a gas form so that the patient can breathe it in. All right, so we are going to move forward to administration routes. Now, drugs have to get into the body to be able to work, right? And so the way that they get in is through an administration route. And drugs are designed with this in mind, all right? And when they are, that means that that drug can only be administered via that specific route. So this means that they are not interchangeable. If a medication is designed to be administered through injection, like Zofran, should be administered through injection. Drinking it is not a good idea, all right? It shouldn't be administered by any other route. Now, two categories of medication administration routes are enteral and parenteral. Enteral meaning through the gastrointestinal tract. This can happen in one of two ways, either orally or rectally. Now, oral is going to be the most common way to administer medications, but again, it's very rare in the surgical setting for the reasons we have already discussed. So you may see the oral route written as capital P, capital O, PO. So this is an abbreviation for the Latin term per os, which means by mouth. All right, so if something is PO, that means you take it by your mouth. All right, now medications giving orally take longer to take effect, and the time that elapses between taking a medication or the administration of a medication and when we see the effects of it in the body, that time lapse is called the onset. So when we take a pill, it has a longer onset. Think about if you have a headache, all right? When you take ibuprofen, Tylenol, Advil, something of that sort, it's probably going to take 20 to 30 minutes before you start feeling some relief, all right? That is the onset. However, it typically, when we take something by mouth, it has a longer onset, so it takes longer for us to feel the effect, but it's going to last longer in the body. And how long the effect lasts in the body, we call that the duration. So pills taking orally have a longer onset and a longer duration. So to review, enteral means through the GI tract. However, some medications are inactivated when they pass through the stomach. So because of that, those medications need to be given parenterally. And parenteral refers to any route other than the digestive tract, okay? So some of the most common types of parenteral routes are topical, subcutaneous, intramuscular, and intravenous. And most medications administered in surgery are going to be administered parenterally. So we're going to spend some time talking about each of those routes in detail. So first up, topical. Topical medications are those that are applied to either the skin or to a mucous membrane lined cavity. And these medications have either a local effect or a systemic effect. Local meaning they work at the site of application. Wherever you put it on, it just works right there. An example of a topical medication that works at the site of application is steroid cream or maybe some antibiotic ointments. Topical medications that have a systemic effect mean that they're going to have an effect on the entire body. And a good example of this are transdermal patches that we stick on the skin, such as those that are used for hormone replacement therapy, for helping individuals to quit smoking, or for motion sickness. Those are some good examples of topical medications that have a systemic effect on the body. So it takes some time for topical medications to absorb through the skin. However, if we apply these topical medications to a blood supply rich mucous membrane, they're going to absorb much more quickly. Some common topical medications used in surgery are various antibiotic ointments, topical hemostatic agents, antibiotic irrigation, and some topical irrigants such as heparin mixed with saline. So now that we have a better understanding of topical medication, let's talk about instillation. Now, examples of medications commonly used that are administered by instillation include tetracaine eye drops, or that are used to reduce pain during cataract removal, Afrin for vasoconstriction in the nose prior to sinus surgery, lidocaine jelly in the urethra prior to a cystoscopy to reduce pain, contrast media used in the biliary tract during a cholangiogram, and methylene blue in the uterus to determine tube patency. So these medications are going to be inserted into mucous membrane lined cavities, again, like the examples showed, in the eye, the nose, the urethra, those sort of things. Then lastly, the inhalation route. Like it sounds, administration via inhalation indicates that these medications are going to be inhaled through the nose or the mouth. And they can also, it's important to note that instillation medications and inhalation medications can both be considered topical. Right, so now that we have a better idea of some topical administration routes or topical instillation and inhalation routes, let's talk about parenteral routes of administration. So as I mentioned previously, most drugs used in surgery are going to be administered through the third and final drug administration route, which is parenteral. Now, parenteral routes include several types. Remember, it's any route besides the GI tract. So we're going to talk about the more common ones first, which are subcutaneous, which is abbreviated SC, intramuscular, which is abbreviated IM, intravenous, which is IV, and IV injection. So of these, the most common one used to administer medications in surgery is going to be IV injection. And you can take a peek at figure 1.12 from the text, and that will give you a better idea of these. Now, subcutaneous injections are going to be those that are given just below the skin into the subcutaneous layer. Remember, that's where dermis and epidermis come together. Common sites are upper lateral aspect of the arm, the anterior thigh, and the abdomen. Injections here, depending on blood flow, they're going to be absorbed fairly rapidly. And in surgery, we don't really use this route a lot, except for in rare cases where they might inject heparin subcutaneously. But I've never witnessed that in my time working in the OR. Now, intramuscular injections are going to be administered into a large muscle, such as the deltoids, the glutes, or the vastus lateralis. These medications are going to be absorbed very quickly via this route because there is a significant blood supply in the muscles. So Toradol, which is a non-steroidal anti-inflammatory drug, is sometimes given in surgery by the anesthesia care provider to provide post-op pain relief. So Toradol would be an example of an intramuscular injection. In surgery, it's very important for the surgeon to inject local anesthetic at the surgery site. So later on, several chapters in, we will discuss local anesthetics in greater detail, but it is very common for us to have local anesthetic on the field that the surgeon is going to inject right at the surgical site. But like I mentioned before, most medications are administered through the IV during surgery, and this is typically going to be performed by the anesthesia care provider. Drugs, they may be given as a bolus, which is all at once, or delivered slowly over time. The absorption of medications administered IV are going to be absorbed immediately. So they're going to have a really quick onset because they go directly into the bloodstream. So let's going to talk about a few not so common parenteral routes. So other parenteral routes, like the one shown here, as I said, are used less often. They include intradermal, intraarticular, intrathecal, and intracardiac. Now, intradermal injections, they are the ones that are given between the layers of the skin, and this is our TB test, or allergy testing is done this way as well. Intraarticular medications are given into the joint space. An example would be some sort of anti-inflammatory agent, such as dexamethasone or something like that. Intrathecal medications are those that are administered via a catheter that goes into the subarachnoid space and into the cerebral spinal fluid, and an epidural is a common example of this one. And then during cardiac resuscitation, sometimes drugs such as epinephrine might be injected directly into the heart, and this is referred to as intracardiac injection. So take a few minutes and reflect on what you've learned so far. I know we've talked about lots of stuff, and then list 3 of those things that you learned that you didn't already know. All right. So are you hanging in there with me? I know this is a lot of information, but we only have 2 more concepts to discuss, and those are pharmacokinetics and pharmacodynamics. Pharmacokinetics. That is defined as the study of how the body processes drugs, whereas pharmacodynamics examines how the action of the drug affects the body. So pharmacokinetics, how the body acts on the drug, and pharmacodynamics, how the drug acts on the body. All right, so first we're going to talk about pharmacokinetics. And if you take a look at table 1.7 in the text, you're going to see that there are 4 processes associated with pharmacokinetics. And these are absorption, distribution. So let me back up. Absorption, how is it going to get in? Distribution, where is it going to go? Biotransformation, or also called metabolism, how is it going to get broken down? And then lastly, excretion, how does it leave? All right, so we're going to look at each of these in a bit more detail. So as I mentioned, pharmacokinetics involves absorption, distribution, biotransformation, also called metabolism, and excretion. So think way back to chemistry class. All right, kinetics, remember, has to do with forces, energy, and motion. So you can think of pharmacokinetics as the force or effect that the body has on a medication as it moves through the body. So the first step in the process in pharmacokinetics is absorption. So in absorption, the drug is taken into the body and it's going to move away from the administration site and towards the bloodstream. Its goal is to get in the bloodstream. Now, the administration routes that we discussed earlier, those are going to determine which body systems are involved. Medications absorbed through the skin are going to absorb a lot more slowly than those administered in the IV. Those administered in the IV, like I said, are going to absorb immediately. And those absorbed through the GI tract are going to be somewhere in between those extremes, right? So on this slide, you can see the process of absorption of the medication administered via the oral route. It's also important to note that solubility makes a difference, and the solubility of a drug is its ability to be dissolved. So that's going to affect the absorption rate. If the drug dissolves really fast, it's going to be absorbed more quickly, but if it dissolves really slow, it's going to take a lot longer for the medication to be absorbed. So certain factors are going to impact how quickly drugs are absorbed, right? Before a drug can be absorbed, again, it has to be dissolved. Remember, solubility equals dissolvability. So administration route, blood supply to the area, and drug solubility are 3 major factors that impact absorption. And if the vascular supply to the area is significant, then it's going to absorb more quickly. But if there's not a lot of vascular supply, then of course it's going to absorb a lot more slowly. So oral absorption is also affected by a variety of factors. remember, the drug is going to have to pass through the digestive system, and there are a lot of factors that can influence absorption, and those are the pH. If a patient has diarrhea, then the medication is going to pass much more quickly through the system. Remember, in the small intestine is where nutrients and molecules are absorbed. So if the patient has diarrhea, there's not going to be as much time for that medication to get absorbed, and so not a lot of the patient's not going to get a lot of the medication. Conversely, if a patient has constipation, then the contents in the intestine can be sitting in there for a really long time, and that could mean that too much of the drug gets absorbed, and potentially the patient ends up with some sort of drug toxicity. So the second process associated with pharmacokinetics is called distribution. If you distribute something, right, you like pass it out, right, along. And so after the drug is absorbed into the bloodstream is going to whisk it away. And that means it's going to distribute it. So this action, again, is carried out by the vascular system. And once it enters circulation, it's hopefully going to be on its way to the site of action. Now, once it arrives at the site of action, the drug is going to eventually leave the blood vessel, all right? It's going to diffuse out of the bloodstream. It's going to move through that very thin wall of the capillary. Remember, capillaries are so small that blood cells can only march through one by one, right? So, and their walls are really, really thin. So the molecules of the medication are eventually going to move out of those capillaries and into the interstitial spaces, which are the spaces between the cells. And eventually, they're going to make their way into the cell, right? Now, when we talk about distribution, we have to talk about bioavailability, and this refers to the degree to which the drug molecule reaches the site of action to exert its effect. So in other words, it's how much drug is left to do the job once it reaches the site of action. And there are a lot of factors that can influence bioavailability. One of those is the acid-base balance. So when there is a change in pH level, this can significantly affect the bioavailability. Also, the size of the drug. If the molecules of the drug are really small, it's going to be easier for them to pass through the plasma membrane. Remember, their goal is to get into the cell where they can, elicit their effect. They can do their job. A third thing that can influence bioavailability is something called lipid solubility. So those molecules that are lipophilic, which means they're fat-loving, they're going to pass more easily than those that are hydrophilic, which means they're water-loving. Remember, think back to anatomy when you studied the cell. Now, right, the cell has what's called a phospholipid bilayer. That's the plasma membrane, right? And the cell is surrounded with water outside and inside. So if you have a molecule that loves water, well, it's really not even going to want to leave the interstitial space, right? Because it loves just hanging out there. And also remember how the phospholipids arrange themselves in the plasma membrane. Their water-loving heads are to the outside, and their hydrophobic tails are on the inside. Molecules that are lipophilic more easily pass through the membrane. These are like steroids and hormones, testosterone, those kinds of molecules that are fat loving, they're just going to slip right through the plasma membrane. Now, those that are hydrophilic, they love water, well, they have to take a special pathway, and there's these specialized channels that will move those molecules, right? So that can affect lipid solubility, can impact bioavailability. And then the last thing I have for you here is ionization of the drug molecule. So those molecules that are non-ionized, which means they don't have polarity, they don't have a positive charge or a negative charge, right? That's going to mean they're going to be more swayed to like attract to someone that's the opposite, right? Opposites attract, pluses attract minuses. It's going to be more difficult for them to pass through the membranes if they are ionized. Okay, so a few factors that impact how quickly the drug reaches the action site. Now, these are going to include, and this just makes sense to me, the general condition of the patient's circulatory system, the effective blood flow to the site of action, and the extent of something called plasma protein binding. Now, this is abbreviated PPB, and plasma protein binding involves the blood plasma, and it has a major impact on drugs because drugs are carried by the blood in the blood, right? Remember, plasma is the liquid portion of blood, and it contains these amazing proteins. So just a quick review of blood structure. Remember, blood is made up of formed elements and plasma. The formed elements are cells. So we have red blood cells, white blood cells, and thrombocytes. You might have heard them called platelets. And then the rest of it is the plasma. And that is the liquid part of the blood. And like I said, it has a bunch of proteins in there. Now, I'm telling you this because the proteins play a major role in how the drug affects the binding site, right? So during the plasma protein binding, right, some of the molecules bind to these proteins that are just floating around in the plasma. The drug binding is going to be dependent on how many plasma proteins are there in the blood and something called drug binding affinity. All right, some drugs have a very high affinity for binding to these plasma proteins, while others could care less, right? So what happens? We have these plasma proteins floating around in the blood, and we have a drug that has a high affinity for binding to these proteins. So what's going to happen is these molecules of the drug are going to bind to the proteins, all right, but not all of the molecules, but let's say the majority of them, right? That means that there are going to be less molecules of the drug floating around freely in the plasma. And these are the ones that are going to diffuse out and interact with the binding site. So because when we have drugs that are called highly bound, we're going to have a longer duration in the body because, again, there are less free drug molecules available to bind to the site of action. And because of that, highly bound drugs are going to stay in the body a lot longer. So remember, if a drug molecule is unbound, that means that it's free to go and bind to the site of action. And then they have a special term for those free molecules that are unbound. We call them bioactive. Bioactive. The ones that are unbound. They don't have a seat at the table with the protein, all right? They're just milling about. So, because plasma proteins can bind with many different drug molecules, there's competition. So plasma proteins, they can bind with many different types of drug molecules. We refer to that as being unspecific. So they don't care which drugs bind. They're like, meh, we don't care. Everybody's welcome, right? So there's competition because they don't care what molecules bind to them, drug molecules. Also, they compete with other drug molecules for binding sites, okay, which can change the amount of drug availability. So let's talk about the example that the book gives. The book gives the example of a patient that is taking warfarin, and warfarin is a medication that thins the blood. It is an anticoagulant. All right. Warfarin is also considered a highly bound drug molecule. Remember, this means that the majority of the drug molecules are going to bind to the proteins, and then there are going to be very few free drug molecules to bind at the site of action at any given time. So let's say the patient takes aspirin. Remember, aspirin is also a blood thinner. So aspirin is now going to be competing with warfarin for those binding sites. This means that there are going to be fewer seats left at the table for warfarin, and consequently, more free molecules of warfarin are going to be wandering about and bioactive, free to bind at the site of action. So this can leave the patient dangerously anticoagulated, right? Because they are getting a higher dose of warfarin. And so the more than an expected amount of drug can lead to what we call over-medication. Examples of highly bound drugs that we use in surgery are propofol, which we already talked about, fentanyl, and diazepam. Unfortunately, the plasma protein binding process is irreversible, and some ways that we can lower unbound drug molecules is through metabolism or excretion, which we're going to talk about coming up here. But don't forget to take a peek at figure 1.14, which gives a good example of the plasma protein binding process. Okay, so after distribution, that was that whole distribution thing. There's going to be some unbound drug remaining that did not get used up. And eventually, these unbound drugs, right, they're traveling in the cardiovascular system. They're going to arrive at the liver. The liver is the primary place where biotransformation takes place. Now, biotransformation and metabolism, we use those to mean the same thing. So I might say biotransformation, I might say metabolism, they mean the same thing. So as the term biotransformation suggests, this is the process that changes the drug's chemical composition. And the main goal of the process is to change lipid-soluble drug molecules into water-soluble molecules so that they can be excreted more easily. But there are some factors that can affect the metabolic rate, and these include the health of the liver and something called the first pass effect. Now, the first pass effect refers to when we take drugs orally. Now, remember, these drugs, they're gonna be subject to the hepatic portal system, right? This is like a safety mechanism so that whatever we ingested doesn't just go right into our bloodstream, but gets filtered through our liver first. So these drugs are going to enter the liver through the hepatic portal system prior to entering circulation. And because of that, they can be severely altered by that process, or they can be inactivated altogether, which is going to impact the drug's effectiveness. So, how does the liver do this? Well, the liver makes these amazing enzymes that help to break down drug molecules, and the effectiveness of the liver enzymes to break down or metabolize the drug molecules depends on a bunch of factors. Those include the patient's age, their nutritional status, if they have any organ disease, and any concurrent drug therapy that they're taking. I was also reading an article that indicated that genetics can also be a factor there. So it's important to note that unbound drug molecules are the only drug molecules available to exert effects on the body, and those are the only ones that can be biotransformed. So there are some drugs that can be completely broken down by the liver. Other drugs aren't broken down at all, but according to the text, most drugs are at least partially broken down. All right, so one last thing here, I think, about biotransformation before we move on to excretion is something called prodrugs. And prodrugs are inactive when they are administered, but they going through the process of biotransformation, they become switched on, they become activated. So an example of this is the anti-glaucoma drug called dipivefrin. And this drug is administered in the eye, and it's broken down at the site of administration through a process called hydrolysis. And hydrolysis, right? The breaking down of something with water. Remember, water carved the Grand Canyon, so it does have the power to break bonds in molecules. So the drug goes in the eye, the water molecules in the eye react with the medication, and the result is two entirely different molecules, epinephrine and pivelic acid. So, this is going to wrap up our discussion on biotransformation. And next, we're going to learn about the last process of associated with pharmacokinetics, which is excretion. All right, so drugs that are taken into the body, right? They're absorbed, they're distributed, they're metabolized, and lastly, they are excreted. So some drugs are excreted in the bile or in feces. Some are actually excreted through the skin, but the majority of them are excreted in the urine. So take a peek at figure 1.16 for a better idea of how excretion occurs. But what happens is the newly biotransformed drug is going to leave the liver. Remember, that's the primary place for biotransformation or metabolization. And so it's going to leave the liver via the bloodstream, and it's going to go to the kidneys. All right. And it's going to be filtered out by the glomerulus. Remember, that's the glomeruli are the filtration units of the kidneys. We have bazillions of them, right? So they're going to go to work filtering out these bioactive or biotransformed, drug molecules. So then tubular secretion is going to use cellular energy to force drugs and their metabolites from the bloodstream, and they will become urine and get excreted from the body. Now, something called the glomerular filtration rate, which corresponds to not only how well your little filters in your kidney are working, but perhaps how many you have, because over time, as we age, we lose glomeruli, but kidney disease can also impact that as well. So renal failure, pH of urine, and the concentration of drug molecules in the plasma can also be factors that impact the excretion rate. So that's going to conclude our discussion about pharmacokinetics, which is, remember, how the body processes the drug, how the body acts on the drug. So our final topic is going to be pharmacodynamics. Remember, we said that pharmacodynamics is the study of how drugs exert their effects on the body. So here we're going to talk about what happens at the site of action. And it's important to note that the body is going to respond to different drugs in varying degrees and at varying rates, and sometimes varying from individual to individual. So next, let's take a look at some terms associated with pharmacodynamics. Agonist. Agonist drugs are those drugs that have an affinity, or they have a like for a receptor, all right? And they're going to cause a particular response when they bind with that receptor. You can think of this like a lock and key situation. There's the receptor, the drug has an affinity for that receptor. It's the key that fits into the lock, and it elicits a particular response. An example of an agonist drug is succinylcholine, which is pretty common, anesthetic agent that they use. But neurotransmitters like acetylcholine are also considered to be agonists. They're lock and key, which elicits a particular response. Now, drugs that bind to receptors to inhibit a response, those are called antagonists or receptor blockers. Now, antagonists can be competitive, which means they can bind to the sites where the agonist would bind, preventing the agonist from binding there so that it can't elicit a response, or non-competitive. And non-competitive means the agonist alters the binding site in some sort of way that makes it impossible for the agonist to then bind there. Either way, an antagonist is inhibiting a response. Now, drug antagonism, it's often responsible for what we call drug interactions, and some of those are not desired interactions. Individuals that take multiple medications are at even higher risk of drug-drug interactions. And in some cases, drugs can actually cancel each other out. And then in other situations, they can reduce the effects of another drug. Now let's talk about synergists. Synergists are drugs that enhance the effect of another drug. So we talked about aspirin and warfarin previously, and this is an example of a synergistic relationship where aspirin is going to increase the effect of warfarin, right? And then the result is that we have an over anticoagulated patient. It's important to note that not all drug actions are receptor type interactions. Some actually interfere with certain aspects of bacterial cell metabolism, like antibiotics will do that, or others interact with specific enzymes. In addition, drugs such as mannitol which is a diuretic, is a non-specific interaction that reduces the reabsorption of water. So this is going to increase urine output in our patient. Some other terms used to clarify aspects of pharmacodynamics include indication, contraindication, onset, and duration. The reason for giving a medication is going to be referred to as the indication. The reason or purpose for giving a medication is the indication. Now, the contraindication is going to be the opposite. That's going to be the reason we wouldn't want to give a patient a particular drug. And then the onset. The onset is the time between the administration of the drug and the first sign of its effects, which we talked about before. And then lastly, the duration. The duration is the time between the onset and the disappearance of the drug's effect. And some drugs, such as propofol, they have a very short duration. It's like 6 to 8 minutes, whereas other drugs, such as warfarin, it can be 2 to 5 days. So if we have a patient that is taking warfarin and they need to have surgery, we may ask them to stop taking their warfarin up to 5 days prior to their surgery. A couple more here: side effect, adverse effect, hypersensitivity, and idiosyncratic drug reactions. Side effect and adverse effect are used to describe the body's response or reaction to medication. So side effects are rarely serious, but are usually unavoidable. They're also predictable, but it's not something that we intended for the drug to do. An example could be after taking an antihistamine, you might feel sleepy. An adverse effect is one that is an undesired or potentially harmful effect, and that could include things like nausea, vomiting, drug toxicity, hypersensitivity, and something called idiosyncratic, which means like an idiosyncrasy is like we don't know, like it was unusual, it was not known, it was something that we weren't aware of that could happen. Okay, so we are at the end of our first lecture on pharmacology. Thank you so much for listening to this lecture regarding the basics of pharmacology. I know it's a lot to take in. It might help to listen to the lecture more than once, or maybe make flashcards of the various concepts and terms. So I will see you next time when we talk about medication development, regulation, and resources.